Thanks, Lauren. I'm really excited this morning to introduce our CCC speaker, Dr. Joseph Lewnard. Dr. Lewnard is an assistant professor of epidemiology at the School of Public Health at UC Berkeley. He received his bachelor degree at McGill University, double majoring in music and geography. And then he quickly became interested in infectious disease epidemiology, where he went to get his PhD at Yale University and then subsequently postdoced with Dr. Mark Lipsitch at the Harvard T.H. Chan School of Public Health. And his work encompasses quite a few facets, but it mainly centers around statistical modeling of infectious diseases, particularly pediatric diseases and vaccines like streptococcus and rotavirus. And he's an expert on statistical estimation of vaccine efficacy and other clinical estimation features. So his work, I just chose a few of his publications that I thought were noteworthy to discuss really briefly right now. He, in 2014, with one of our collaborators, Alison Galvani, published one of the most intricate models of the Ebola epidemic in Montserrado, Liberia, during the epidemic, and really trying to understand and direct policy towards strategies for controlling the epidemic. One of the most interesting publications that I saw of his is actually, you may remember during the Rio Olympics, people were very concerned about the risk for not only travelers getting Zika, but also bringing it back to their home countries. And he published a study that estimated that there would be a low risk of this, of the international Zika spread during the Olympics, which I found really interesting at the time and still do. And then he has done quite a bit of really important work in one of my favorite areas involving interactions of pathogens and looking at the interactions and competitive dynamics between common respiratory diseases in children. And then also he's looked very closely at vaccine efficacy and vaccine waning, and has tied vaccine waning to the mumps reemergence in the US, finding that protection wanes roughly 30 years after vaccination, which has really critical implications for public health strategy. And overall, I've just really been continually impressed with his ability to combine complex clinical studies with intricate statistical modeling to tease apart disease dynamics. And I think he's really showcased this looking at quite a few of his COVID-19 studies. So some of you probably recognize his name from some of the papers we've reviewed in Journal Club, as well as just mentioned throughout over the past 6 months, looking at a cohort study of hospitalized COVID-19 patients from California and Washington, some of the parameters of which are informing our epidemiological models. He published a critique, or maybe not a critique, but a word of caution about using the IHME model for predicting the course of the COVID-19 pandemic. And then also has been a loud voice, not just for COVID-19, but in general about thinking through the principles and values of projections and forecasts. And then he had a commentary paper that was first released on March 23rd that, as I was looking through his papers, I just thought this quote was so important and also timeless through this whole pandemic. And I just wanted to read it real quick, where he said, "The effectiveness of societal impact of quarantine and social distancing will depend on the credibility of public health authorities, political leaders, and institutions. It is important that policymakers maintain the public's trust through the use of evidence-based interventions and fully transparent fact-based communication." I thought that was very prescient for the course this kind of pandemic has taken through a lot of the globe. Anyway, today he's going to be talking about, I believe, a different COVID-19 study looking at transmission dynamics in two Indian states. Sorry. So with that, I'll let him take it away.
All right, thank you, Spencer, and thank you everybody for being here, and thank you so much for the invitation. I really appreciate it, and I'm excited to talk to you all. So I have some slides about this work in India. There are too many of them, I will also, sort of accelerate through, but please at any point, holler if you'd like to cut in and talk about anything that's coming up, or other things that are not coming up as well, because I'm happy to do that. Is my sidebar of video panel showing up on people's screen, or is it not in the way? It's good. Okay, all right, thank you. So I'm going to be talking about a study that we recently published looking at COVID-19 in 2 Indian states with a huge team. There are thousands of people involved in this study, and so that no author list can do justice to that. But highlighting here in particular, J. Radhakrishnan and K.S. Jawahar Reddy, who are the chief health secretaries of the states of Andhra Pradesh and Tamil Nadu, which collectively are about 10% of the Indian population, and have led an enormous effort to respond to COVID-19 in this very difficult setting. So as some context of where we're coming from in this paper, and something that I think that we really wanted to respond to, we have been with colleagues of mine who are based in India, working with these 2 state ministries to inform their response to COVID, and answer questions that came up in real time where they felt quantitative analysis could be useful. And we entered into this whole landscape knowing a lot about, as of, let's say, even as early as April, really, the epidemiology and transmission dynamics and clinical spectrum of SARS-CoV-2 infection from first China, where probably the most data per patient has been made available, and where a lot of learning has happened from clinical experience, and then later Italy, and subsequently the US and other really, essentially high income settings. However, the overwhelming majority of the population at risk for COVID-19 resides in low and middle income countries. Also not noted on this slide, but something that really comes to mind from the quote that Spencer just highlighted, the overwhelming majority of the population subjected to fairly stringent social distancing type interventions also resides in low and middle income countries. And we've been informing to date all of our response to COVID from our observations on the epidemiology, clinical aspects, and transmission dynamics in higher income settings, with almost no primary data to inform what aspects of this might differ or be similar in low income countries. And I think this has some significance, in particular when you think about the deleterious effects of school closures, for instance. In the United States, they are all the more pronounced in a low income setting where many of the children currently out of school will never go back. Because they're entering the workforce, and there are all kinds of, more severe consequences, likewise, food insecurity, et cetera. So we wanted to actually make some data available from a setting where good quality epidemiology was being done. So brief summary, these are 2 states on the east coast of India. In the south, Chennai is the main city of Tamil Nadu and the largest city in this region, and was the epicenter of the epidemic early on, where it was first introduced in the states. Essentially, there are 2 kind of clusters of focus emerged as of the early summer, with sort of a center of transmission in Tamil Nadu in Chennai, which spanned outward to surrounding districts, and then also in Madurai, which is the sort of second city of that state. Incidence remained low in the northern state of Andhra Pradesh until later on, where it ultimately eclipsed what was going on in Tamil Nadu. This is a far more rural and agricultural state, whereas Tamil Nadu is more industrialized and, again, centered on these 2 cities. Interestingly enough, there was sort of a lower, to this date actually, still a lower permeation of the epidemic in more rural districts outside the main cities of Tamil Nadu. In terms of what this actually looked like, looking at the individual districts here, Chennai actually saw sort of a peak in cases around July, which has been turning downward, and we're now working with serology data from comprehensive serosurveys to investigate, what is going on there, and was this a saturation of the epidemic in the susceptible population or not, or was it likely more due to control measures? This is just an image of some of the southern districts, and centered in Madurai, with cases actually at higher incidence rates, but sort of increasing in similar time frame to what we saw in Madurai, which is the second city. Over the course of the epidemic in India, there have been different phases of lockdown and unlock in terms of the terminology that's been used. And I think everybody's very familiar, in particular, with the 3-week countrywide lockdown, which I've plotted here in the red bin, where we saw a reduction in the reproductive number from roughly a range of 2-ish to 4-ish. In the 2 states, although this is a difficult quantity to estimate early when surveillance is more patchy and testing is increasing over time, as everybody knows. At least some loose estimates here in the range of a little bit above 2 that settled down in a range that is not below 1 but closer to 1. And so although the epidemic has not by any means been brought under control as of July, August in these settings, it was in better shape than it would have been had there not been a lockdown from these plots. We were interested first in some fundamental aspects of the epidemiology in this setting, such as how the different demographic distribution of India's population, being a younger country compared to the epidemiology in the US and in other high income settings. And one of the very sort of interesting findings that came from this is that it is not accurate to just project age-specific incidence from the US or age-specific relative incidence from the US to the Indian population and expect parallel trends. Interestingly enough, whereas we see sort of an uptick in infections as well as mortality, of course, towards the oldest ages in the US, we actually saw lower cases occurring in the oldest age groups in India, where you'd expect, first of all, that surveillance is most accurate since there's a more severe clinical presentation in those ages, usually more awareness of COVID as a disease affecting those ages and everything else, which resulted in a death distribution that's sort of centered around the age of 60 years, much in contrast to the US, where the greatest proportion of deaths is occurring in the very oldest age groups. So this is sort of a interesting discrepancy. We do not have a direct explanation for this, but one thought is that in India, people who are living to age 85 or 75 are far and away wealthier than the general population, and we might expect that they are relatively protected just in terms of the wider socioeconomic gap occurring at those ages relative to people that are not surviving to age 75 or 85. We had sufficient data to estimate 30-day case fatality ratios in fairly good precision. So this is estimates looking at different age strata based on CDC groupings where our comparisons were possible. Unfortunately, CDC refuses to use the 10-year age groupings that the rest of the world is using. So that's a little irritating for comparing to other studies, but overall we're seeing a 2% case fatality ratio, a little bit higher among men than among women, and then similar to the US, a bit of a uptick at age 0 to 4 years relative to subsequent 5 to 17-year age group, and then a steady increase from the 5 to 17-year age group onward. And this is all repeated in both men and women, or boys and girls, reaching 16.5% at age 85 plus years. Looking at predictors of mortality here, there's not a whole lot of rich demographic and socioeconomic data, although that's being added, at least from geocoding of all of the cases right now. We see here again just a reiteration of the increased risk of death towards older age groups, and then also a kind of interesting pattern of reduced risk of death towards later points in the epidemic, which likely reflects both testing of a wider set of people, but possibly also improvements in clinical care. One of the very interesting findings that came out of this is that a median age of death is just above, not median age, but a median time of death is just right around the first week after a case is diagnosed, which could, in part reflect that cases are being ascertained at a later point in their illness. However, there's pretty widespread community-based testing, including from home-to-home visits in areas with active transmission, which suggests, although we don't have very conclusive proof of this here, that there's also faster clinical deterioration in this setting or poorer access to high-quality care. This is, just a notable contrast to work that you mentioned that we did earlier in the epidemic in California and Washington State with the Kaiser Permanente health system, where on average for people who were dying, it was taking 2 weeks, and a substantial proportion were taking well into, an area of almost 3 weeks even. So which, just a very different kind of, impact on hospitalization resources and needs for management of cases. One of the other interesting findings that came from this, there's active reporting of all known comorbidities among patients who die. Unfortunately, this is not done for patients who are not dying, so one can't look at a risk factor, but in terms of the prevalence of comorbidities among people who die, it's far higher than you'd expect in the general Indian population, and this can probably explain why what is going on, at least with these people who are dying at fairly young ages. There's probably a significant role of comorbidities, just because it's hard to picture, seeing a 46 to 51% prevalence of diabetes in general population samples at ages 45 or 65 years, for instance. Likewise, hypertension, these are the major comorbidities. In comparison in the US, the prevalence of comorbidities, at least as of the most recent MMWR that reported this among comprehensive surveys of fatal cases, was about 20%. So likely this is, a byproduct of the fact that, or related to the fact that deaths are occurring among younger age groups in India on average. One of the biggest parts of the study was that we had comprehensive access to contact tracing that had been done in the 2 states. And there were 2 broad swaths of contacts being defined as high risk and low risk, basically distinguished by the nature of direct, either sustained or skin to skin or body fluid type contacts that happen between people. With the exception also, there was a sort of a special category for high risk travel exposures that were fairly intense. Unsurprisingly, given that this is now being reported pretty much everywhere that people look for it, and not just with SARS-CoV-2, but probably being appreciated more with SARS-CoV-2, there was substantial evidence for super spreading in terms of over-dispersed distribution of the number of positive contacts identified among those tested who were traced from each index case. With 71% of people, it's plotted on the log scale, it's not easy to see, but 71% of people having 0 infected contacts identified, and a small, proportion of individuals accounting for the overwhelming majority of transmission. We were able to stratify secondary attack rates also by different kinds of settings. Overall, about a 10.5% secondary attack rate among people who were defined as high-risk contacts versus 4.5% among low-risk contacts, ranging from 2.6% in the community to 9% of the household. We had this kind of very high-risk travel exposure, which was associated with 80% secondary attack rates, but that was really a kind of unique exposure pre-mask era, and not a whole lot of people traced that way. So this got some head turns, but it's fairly small source of all transmission that's going on in the setting. Interestingly, there were some high-risk healthcare exposures identified in the early phases of contact tracing when inadvertently healthcare providers had unprotected contact or otherwise defined as high-risk contact with patients, and there was a very low risk of transmission identified in those scenarios. I've previously talked about the kind of Mossong paper as a background for going into what we looked at with the social mixing, but some interesting things to note. If we look at the distribution of the age of index cases among all those contacts who were traced and identified, we see almost everybody who was traced, or the largest share of people who were traced were being traced from a contact around young to middle adult age, so age roughly 20 to 45. The greatest share of contacts, if we looked at this from the converse perspective, who are being traced are children of index patients. So there's pretty rich testing of children in this study looking at household transmission. What we see when we look at the distribution of actual infection pairs is that, as before, the majority of, or the largest share of transmission is for any age of contact is coming from this, being limited to just positive contacts, true transmission pairs, is coming from, again, kind of young to middle-aged adults, ages 20 to 45-ish. And we can see, two kind of prominent diagonals here, and almost a square cut out of the classic Mossong contact matrices during this time of school closures, when children are really only interacting with close household or other community contacts and not involved in school or things like that. Here we see kind of an older age of parents likely transmitting to older ages of children. So this first diagonal, and then of course, as you'd expect, a kind of same age diagonal going through young and middle-aged adulthood, and then last sort of a fainter but still evident higher proportion of transmission coming from young adult age groups to older adults. One of the more striking findings that did come from this is that when we looked at strata by the age of contacts and the age of index cases to whom from whom transmission was being traced, we were able to see that this diagonal of same age transmission really occurred throughout, and it was not just an issue of the number of contacts that people were having, but the risk of infection given contact occurred was highest in every age stratum from an index case of the same age, which likely speaks to something about the nature of interactions that happen among same age pairs, which are probably closer in general than intergenerational interactions. Here, one of the kind of more surprising parts of this was that it was also evident among children, and maybe even most strongly evident among children, where we can see this kind of peak of the highest secondary attack rate migrating with each child age group to the context of the same age. And then again, also in the context of older adults, we were able to see that older adults traced to another older adult were the highest risk of being infected. This again does not say that children are the most important group for transmission. We see here quite strongly that the majority of transmission that's being traced here is being traced from middle-aged and young adults. However, in the smaller number of scenarios where children were identified to be index cases, there was a very high risk of positivity among same-age contacts. So again, a huge thank you for all of this work. Very little of it is done by anyone on the data analysis stage, and it was possible through large-scale contact tracing and surveillance efforts undertaken by the governments of Tamil Nadu and Andhra Pradesh, as well as some colleagues not listed here, but because we last gave this presentation together at Ramana Lakshminarayan from the Center for Disease Dynamics, Economics and Policy in New Delhi, also affiliated with Princeton, and Brian Wall at Johns Hopkins School of Public Health. I have had a lot of probably interest in the findings about children here. That's probably the most maybe surprising results here, and so I did want to, if it is helpful, I aggregated some figures and classes of essentially the anecdotal evidence that has emerged about the role of children in transmission, which I think is some of the most interesting questions out there. From other studies, I include, for instance, there's a well-reported cluster in Illinois of transmission at a family gathering that ultimately affected, I think, either 11 or 13 people that started with an infected adolescent. Of course, the summer camp outbreak in Georgia that people are likely very familiar with, where there was 44% overall attack rate, highest in children who were campers at that event. And then also some very nice, elegant studies that have looked at transmission in daycare centers, where there's kind of an interesting structure of children as the only bridge between families who are or worker households who are linked to a daycare center but not linked to each other. I don't have a slide for this either, but in parallel, we're doing a large study of infection in Monterey County farm workers here in California, where essentially, socioeconomically not that different a setting from slum communities in India. It is extremely, extremely poor, very low quality housing and prevalent overcrowding. And in that study, we're getting both antibody and PCR current infection. And the main risk factor in this highly crowded population for antibody positivity is having a child in daycare, which is interesting and kind of a striking result here. So I'm curious about the thoughts of this community that follows meticulously the literature that is coming out about children in transmission in different settings. Obviously, we're looking mostly at household transmission of children here, absolutely not schools. Schools were closed during this whole period, but that's one direction I was curious about conversation and thoughts from what we've done here.